Welcome back to Endoscopy Essentials. We are in the middle of the colon, in the middle of complications, bleeding. Hi, Michael. Now it's finished, but then bleeding comes post-procedural. So one of many problems of colonoscopy and polypectomy, right?
Yeah. So I think we're making good progress, but we've got a ways to go. So we've covered perforation, but there's still other aspects. We haven't dealt with recurrence or interval cancer, and we've covered intraprocedural bleeding, but now I'd like to talk about post-procedural bleeding. So this is a big issue because after EMR, it occurs overall in 5 to 7% of cases, and it's particularly prevalent in the right colon, where it occurs with 10 to 12% of cases, and it's resource intensive. The patients go home, and then a day later, 2 days later, we know that 90% of it happens in the first 2 days, and then they'll ring you up. They come back to hospital. They may or may not be hypotensive. There's a whole range of things that can happen.
But that's the severe bleeding, where it's pretty clear, but there's a gray zone. Patient calls you and say there's a little bit of blood.
Yeah, so all the data that we've published around this is what we call significant, clinically significant post-EMR bleeding, which is now, we defined that term, and it's the term that everyone uses in the literature. And it's basically blood that, it's bleeding that generates a deviation in the normal post-operative, post-procedural care plan. So the patient either has to have medical intervention, come back to hospital. If they call you up and they say, we have a bit of blood, and they're passing a bloody bowel action 2 or 3 times a day, that's not clinically significant post-EMR bleeding. It has to be bleeding that brings you back to hospital.
But I mean, if you have a referral system, patient is 100 miles away.
Oh yeah.
How do you deal with that? I mean,
we tell them to stay in Sydney for an extra couple of days.
Okay. So in case of doubt, they can come back. And
So our patients come from all around, and they stay in a hotel opposite the hospital. Usually it's an outpatient procedure, but we'll tell them to stay one night. Most of the bleeding happens just in the first night, as you know. So we'll tell them to stay locally overnight, and if they're fine in the morning, they can make their way home. And then it's uncommon that they have bleeding after that. And the new clip closure and all of that is really.
But here you're on the phone who says, I have a little bit of red blood. Well, what do? Call again in 3 hours and.
No. So we explain. We have an information sheet, and we say to them, if you're passing blood in the stool 2 or 3 times per day, but you otherwise feel well, you're not having significant bleeding. We explain that the way the EMR works, you have an open wound, we can't fully close it, but you're genuinely bleeding if you're passing blood every half hour to an hour, with blood in every bowel action, and there's clots, and then you are bleeding. Yeah.
Okay. Does it work, or do you have
it does work. We do. Since we started.
No lawsuits.
No. Okay. Well, not for that. But since we started clipping in the right colon, we're going to come to that. But we're not troubled by bleeding anymore. It used to be a big source of problems, but it's not a major issue anymore. But we'd have 1 or 2 bleeders every 1 to 2 weeks. We don't have that problem anymore.
And that's just because of clipping? So let's
colon.
start with prevention.
Yeah. So here's the background to it all. Yeah. So, you can see that it generates a lot of anxiety. And then of course, on occasion, you have to go in and stop the bleeding, which is resource intensive. That requires some skill, not always can people get the clip in the right spot or use a coagulating force appropriately. The bleeding risk is 7% overall. And then, of course, even if closure is perfect, it doesn't always stop the bleeding. So the bleeding risk in the colon overall is 7%, but in fact, most of that risk is in the right colon where it's 10 to 12% from hepatic flexure down. Transverse colon bleeding risk is low. Left colon bleeding risk is only 2 to 3%. Rectum, it's probably 5%. So there are 3 randomized controlled trials. This is our own, which was published in Lancet GastroHep, and we randomized 240 patients, clipping versus no clipping, large lesions, and bleeding risk was reduced from. This is a meta-analysis of all the trials. So Albanese, Gupta, and Polt, the Gupta trials, ours.
Which is based on real data, right?
Yeah, it's all
original data.
Yeah, it's all source data, and so bleeding risk is reduced from 9% down to 3%. It was the same in every trial. 3 different centres: Spain, US multi-centre, and Australia 2-centre. So if I just go to the poll study here, 18 site RCT, this many patients, this many polyps, and you can see altogether, but proximal polyps, the risk was the same in our study, 9.6% to 3.3%, and the benefit in distal polyps didn't exist. So the number needed to treat to prevent one bleed was around 15 to 16 in the right colon and overall 28. So basically our practice has changed. We just clip right colon polyps and it works very well. Not perfect, but pretty
it
good.
Means it should become standard, right?
It is the standard of care, and
it's like margin coagulation. It took a while because initially people always say, "Oh no, it's so cumbersome and blah, blah, blah."
Yeah.
But now clipping should be done, right?
Yeah, it's in the current guidelines in the ESG.
Right colon.
Yeah, right colon.
Not transverse colon.
No.
Ascending and cecum.
Yeah, ascending cecum hepatic flexure.
Hepatic flexure.
Because it's hard to tell, and if you're in doubt, proximal transverse, clip away. But the bleeding risk in the transverse is low. But the point you make about the hemostasis, so even if you look at the defect, I mean, you see here, this looks perfect, right? But 24 hours later, so it's you can't really predict based on the defect. So the idea of coagulating visible vessels, I mean...
Yeah, we had that at the last podcast and you said no.
Yeah, so we couldn't show a benefit, but maybe there are a few vessels here that you could coagulate, but even so, we're back here, not a high-risk defect, but still, major bleeding, yeah.
So clipping is standard. If you can't do clipping because it's too large, do you accede to other methods, or we just don't know yet?
So we know that partial clipping in the POL study reduced the risk to about 5%. And it was significant. So, and I think what happens is if you've got a defect like this, and of course in the right colon there are a lot of shearing forces generated to gaseous distension and all these other things, and so if you can just cinch the defect together somewhat, it reduces the tension on the wall, and the vessels that are sort of sublethally injured, they're injured a bit, like they're predisposed to bleeding, but not so much so, then the bleeding risk will be reduced because there's not as much tension within the defect.
But it's mucosa to mucosa, so within the muscular
it's mucosa
layer,
to
it doesn't
mucosa,
make sense.
But what I'm saying is, if you close the defect fully, sure, the bleeding risk is reduced dramatically. But if you can just close a little bit, it's probably sufficient to reduce the tension on the defect.
So like starting from both sides in a very big...
Usually start from one side, but then you might end up with a situation where you can't close enough, but then it can still help. Yeah.
Any new special clips which might be better, or we don't have?
We don't have enough data, and
where you can grasp one side and pull it to the other.
Yeah, there is of course this clip, but there's no conclusive evidence to show that it's better than anything else. Maybe there's a if you think of the history of clipping, like 10 years ago, we just were nowhere near where we are now. So I'm sure it's going to get better and better. And there'll be new clips that will allow us to oppose things, but finally we'll be limited by the size of the defect. Yeah. Massive defects simply can't be closed.
Right. So will be a podcast in a year or so when we have more
Probably.
evidence. And the same is for all the gels and sprays and
What we actually need is a topical adherent hemostatic gel, and something that will stick for 48 hours. It's hemostatic, and that's it. It'll slough off. We don't really have that product at present, but I think it ultimately will come, and that'll revolutionise things, because you won't need to be clipping, which requires
skill and time and
a lot of skill, and it's expensive too.
Yeah. Well, there's a German randomized trial about Purastat in the colon. We'll report about that when it's out.
Yeah. I look forward
It's
to
being written,
Yeah.
so well, we'll see. So, Michael, we spoke about clipping for prevention. That's set for the right colon, and you mentioned it's not always easy. Large defects.
Yeah, I mean, there's definitely an art to it, and we've got much better at it because we've been doing it routinely for, getting close to 10 years. But so as we discussed previously in the perforation episode, you need to identify which side to start from. Usually the side where the fluid pool is, because you want the stem of the clip to fall away from the defect. It's always easier to clip left to right, because just the way the scope's set up, to have the defect at 6 o'clock, aspirate gas, don't push down too much, and try and close the defect. So these are some examples that you can see here. This is not a very big polyp, just nudging on 20 millimeter, and then a nice, so these oval or ellipse shaped defects, commonly polyps are actually that shape. They're not usually circular. They tend to grow that way. So they're easy to close.
They're clip friendly.
Hey,
They're
clip friendly,
yeah,
definitely.
yeah.
And even larger defects. This is in the right colon here. Beautiful granular homogeneous lesion, poster boy actually, lesion, and risk of invasive cancer 0. And this can be closed easily with clips like so. I want to talk a little bit about too the type of clip closure, because there is this idea of mucosal apposition. So you grab some mucosa, and you join it over the top of the defect. That's not true closure. You wouldn't rely on that to close a perforation. What you reliably need for perforation closure is serosa to serosa apposition, which is what the surgeons are doing when they suture things together or close things up. They're not dragging mucosa over the top. So this here is an example of serosa to serosa apposition. You can see that we've got mucosa, submucosa, and serosa and muscle underneath, all joined up by these clips here. You can see the muscle within the defect. So this is full thickness serosa to serosa apposition. What we sometimes find ourselves doing when we're closing in the right colon, because as the defect gets bigger, we're trying not to do this, but you're tending to drag the mucosa over the top of the wound. So these are some older examples of mucosa being dragged over the top of the wound to other mucosa to mucosa apposition. And, maybe it works a bit, but 3 separate examples, and you can see it just doesn't look that secure. And then of course, if we try and close something bigger, so here 9 clips, and then before we even finish, the wound is split apart, and there's a defect there.
And nobody knows what's the situation 1 hour later.
No, that's true.
A nice closure.
No, exactly. That's why, maybe as we discussed,
it's not 0.
Yeah, it's not 0. Yeah. So here's another example, but this is serosa to serosa apposition. So you see here now we changed our technique. We steadfastly avoid this notion of pulling mucosa over the top, but rather start at one edge on the side of the fluid pool, aspirate the gas, shrink the defect down, raise up a mound of tissue, and then try and work sequentially so we can fully close the defect.
So it's a perforation closure strategy.
It's a perforation closure strategy. It requires a bit of skill, And, this is probably going to take 15 to 20 minutes. Like, it takes a bit of time. But this is done to reduce the risk of bleeding.
But at least from the studies, we don't know what everybody did, right? So it might be a mixture of all techniques. And
For sure. I mean, the Pole study was 19 centres. Our study was just really one centre. So we were definitely doing this, but our results were the same as Heiko's study. So, yeah. And here you see the end result, so this is, it takes a bit of skill.
Which may mean 10 minutes EMR and 30 minutes closure.
It could. It well could. It well could. Yeah. So that's why, as we discussed, if we had a reliable topical hemostatic gel that was adherent and could stick on the defect for a couple of days, that
would be ideal because it's quick. Probably.
Yeah, it's quick, easy to apply, doesn't require skill. Uniform approach, operator independent, and then of course we have this thing of the clip artifact, which I don't think we've discussed, but maybe that deserves its own episode. And finally, because we can't close the defect, we end up with this situation of the reclipping of the clipping. So sometimes a small percentage of these patients will bleed, and then if you go in, you'll find the bleeding point between the clips, and then you'll have to fix that.
It looks more messy.
Yeah, and the reason all of this problem exists is because as the defect gets bigger, the area expands quadratically. So if everyone remembers, pi r squared is the area of a circle. So the area of the 2 centimeter polyp is 3.14 times 4, which is 12 or 13. But for a 3 centimeter polyp, the area is actually, more than twice that. It's 28 centimeters. So you increase the radius by a small amount, 1 centimeter, 50%, but you end up, more than doubling or trebling the size of the defect. So, for example, this size defect here, it's massive and a huge polyp. And then if we think, well, let's close it with clips. I don't know what I was thinking, but there's just no prospect of making an impact on that. And then if you were to try and close it by an alternative means, you may, obstruct the lumen of the bowel. These are other examples. These days, this is an older slide. These days, we probably could do a better job of this, but still, it's going to be hard to close. And this one's not so bad. So, but no chance for this guy. Yeah, there's a clip. How are we going to close this?
But if you do a little bit of clipping, as we said before, from both sides, you take a little bit of the tension out better than nothing?
Yeah,
or we don't know.
Well, we know that partial closure reduces the risk. So, for example, this defect now, this slide is probably from 5 years ago, but this defect now, we would start here and apply 3-4 clips and try and bring it together, and this side 3-4 clips, and then we'd have a defect that was sort of like maybe 60% of what it was originally, and the tension, because if the colon's distended, these little vessels here, they're going to be on the full stretch, and if they were transected during the resection phase, on the full stretch they'll be much more prone to bleeding. But if we can close the defect somewhat, then the risk of bleeding will be reduced. It's not an exact science.
Okay, so let's discuss a little bit. We spoke about primary hemostasis or hemostasis during primary resection, intraprocedural bleeding. Basically, the techniques are the same for post-procedural bleeding, but you have to get rid of all the clots. What do? In ulcers, you take a snare sometimes, and if you have a cap, do you scrap them away or?
Well, generally, so we know that 50% of the time you don't need to go back in. The patient, they'll settle, the bleeding will stop spontaneously, maybe even 60 to 70% of the time. So the patient just needs bed rest, resuscitation, and commonly they don't need blood. But if they have ongoing bleeding, we showed this in a separate study with Nick Burgess. If they have ongoing bleeding, passing clots, hypotension, hemoglobin less than 10, they definitely need re-intervention. Do they need bowel preparation? Probably not if it's the first 24 hours, because, you know, they're auto-prepared by the blood and you know where the bleeding point is. And now we've got water jets, we've got big channels on our scopes, and we're always going to the right colon. So just fill the colon with water and make your way around. And you know where to look. And then you need really good suction. Sometimes you need to use a super sucker to clear the clots. It's definitely not as bad as duodenal bleeding. In the duodenum, it's the blood everywhere, and you can really struggle.
That's
but
right,
colon, not so difficult. You just need to make sure. I mean, best if the patient's intubated, because you may need to roll them, and you've got hemodynamic stability. You've got anaesthetic support. These are the situations where you need to do the case. I'm not talking about people who have minor bleeding, and so get rid of all the blood. Maybe sometimes you need adrenaline injection, and then you really want to find the bleeding point. And then our current technique is coagulating forceps to treat the bleeding point and then clip that area up, just that area.
Okay, but what do you do? There are a lot of blood clots all over the place, but you don't see any fresh blood.
Well, you've got to find the defect. Yeah, so you need to clean the defect.
Which is certain or very likely to have bled.
Yeah, well, that's the
because otherwise the risk of recurrence is very high.
Yeah, well, you know, I mean, the bleeding, I mean, it's a post-EMR bleeding, so the bleeding's going to be coming from that defect. And so you've just got to irrigate and add a lot of water and aspirate and just clearing the clots. But generally it's feasible, yeah.
Maybe that's the first niche for the extended closure methods.
At that time?
Yes.
Oh, I think it would be very tricky because you've got all that blood clot
around.
The overview
is bad, and okay.
I think I mean, I think extended closure, if it comes to be, which I hope it does, is going to be best used in a dry colon with good access and no blood and clean defect.
Oh, we must have some stuff for having further podcast, right?
Yeah.
So that's a post-procedural bleeding, and so the poor endoscopist is relieved now?
Yeah, so what you're really asking me is clipping, is the use of clips the panacea for the modern endoscopist? So should they just use clips willy-nilly? And this is the schema that we put together, which is it's like the modern polypectomy schema of endoscopist heart rate versus clip number. And so if I can play it for you, you can see at point here, there's polypectomy, diathermy is applied, and heart rate goes up. But as clips are applied, the endoscopist's heart rate comes down to 80, maybe 60 if he's fit. But clinical benefit remains the same in most situations.
So it's a little bit of overclipping, right?
There's a lot of overclipping.
Okay. Thank you very much, Michael. I'm very much looking forward. We have lots to discuss, recurrences, other issues, other organs even.
Yeah.
But for this time, for this series, thank you very, very much.
My pleasure. Thank you, Thomas.